Hi everybody, this is Retina Mentors. Today we're going to talk about trocars, kinds of trocars, the technique that we use to put them in the eye, and also the particularities that we need to know when we remove the trocars, okay? So first, well, it depends on each brand, but trocars usually are identified by colors. In this brand, the orange one, look in the screen, the orange one is the 23 gauge, the green one is the 25 and the purple one is the 27, but it may change between brands, okay? So today we want to start with valvulated trocars and no valvulated trocars. This here is a no valvulated 23 gauge, and we always start the insertion of the trocars by the infusion one, okay? It's really important because it's when the eye has a good tone to put the first one, and if we lost tone in the eye, we can put the infusion, we can on the infusion and have a better tone for the next two trocars, all right? So first, we're gonna mark here, we put always the trocar with one teeth in the limbus, and then we mark with another ones, okay? In pseudophakic patients, we're gonna enter in 3.5, 3 to 3.5 millimeters, and in phakic patients with a lens a little bit behind, okay, like 4 millimeters from the limbus. Always we insert, well, the most of the cases we insert the infusion in the temporal inferior area because the temporal area is where the pars plana is wider, so it's less probable that we make an injury into the retina, okay? There will be some cases in retina detachments or in choroidal detachments where we choose another unusual location of the infusion, but we will talk about that later, okay? So today it's a normal case. We're going to suppose that it's a diabetic patient with a bleeding, with a vitreous bleeding, so we're going to put the infusion in the temporal inferior area. So we mark here, then with a conjunctival forceps, we're going to simulate here, we're going to move the conjunctiva from the part where we marked, so when we remove it, we can close well that sclerotomy, okay? Then we're going to enter, look the position of my trocar, we're going to enter parallel to the limbus until this mark here, and then we're going to change the position of our hand aiming to the optic nerve, okay? So we're going to repeat it, we're going to mark first. This is a pseudophakic patient, so we're going to enter in the first mark. I move the conjunctiva, I enter here, look, I stop, then I change my hand position to the optic nerve, and if you find resistance, you can turn a little bit the trocar, okay? So we enter there, we grab the trocar with the forceps, and we remove the lancet, okay? When we have the first trocar, always in our first cases, remember, always the infusion trocar needs to be, we need to be sure that it's on the vitreous cavity, okay? So you can do it with a tool like this. I will pressure and then look in the screen. I am sure that the trocar is in the vitreous cavity. I am sure that it's not subretinal or in the suprachoroidal space. So I'm sure to put the infusion on it, okay? So then we're gonna put the infusion. Always we push the infusion. We ask to our assistant to to put on the infusion to avoid have bubbles inside the cavity. When we have pushed the infusion, we close it. And with the infusion closed, we grab the trocar with the forceps and we enter there, okay? I like always to put a tape or something to fix the infusion to 90 degrees of the eye to avoid to lose the infusion during the surgery and to have a trouble, okay? So once that the infusion trocar is on, we're gonna pass with the next trocars, okay? This is only for a demonstration. I'm going to use another kind of trocar. This is a 25 gauge trocar. So I will put the superior ones, okay? So imagine that this is a normal bleeding in the eye, vitreous bleeding. But in case of a retina detachment with a superior tear, I usually like to put the trocars more wide, okay, more like to the 9 and the 3 hours. So that will help me to have a better visualization and an easier treatment of the superior lesions. Okay, as well, we're gonna repeat. This is a routine case of a diabetic patient, so we're gonna put this like in at the 10 of the clock. Okay, look, we mark the same, then we grab the conjunctiva, we move the conjunctiva, and my hand is parallel to the limbus. I enter like that, I stop there, then I change my hand position to the optic nerve and turn a little bit the lancet to avoid make too much pressure, okay? If you feel like the eye is with low pressure, you can on the infusion that you have ready here and have a better pressure in the eye to put the trocar, okay? Then I grab the trocar and I remove the lancet. All right, so that's the second one ready. And we're gonna pass to the third one. Okay, again, the same. This is a right eye and the nose of the patient is not, a problem, but be careful in patients with big nose and the choose of the location of the trocars, okay? Patients with big nose, we will have the trouble in this, in right eyes, in this zone. So maybe if the lesion is in the temporal side of a right eye with a patient with big nose, we will have troubles, okay? So you need to be wise in those cases with patients with big nose or with atrophy of the tissues of the orbital area. So you have a very good location of the trocars since the beginning. And remember, even if you already put the trocars and you're having troubles, before harming the retina, before have a complication, you always can remove one trocar and recolocate another one in a better position, okay? So we're gonna put the third one here, look in the screen, the same with the first teeth on the limbus. I marked the other ones, where here I'm simulating in this bionic eye, so I move the conjunctiva and then the same. Look my hand parallel to the limbus. The idea of this is that it has a self-sealed trocar, okay? I change my hand position, turn a little bit, and that's it. I remove the lancet. And we have, there are the trocars. There are advantages and disadvantages of the valvulated cases. For diabetic patients, I like trocars without valve like this one, because if there is an active bleeding, I can only remove the instrument from the eye, raise a little bit the infusion, and the bleeding with water will be always getting out by these trocars. But in cases where I plan to have air or gas during the surgery, I prefer the valvulated trocars because they have a sealed, more stability in the vitreous cavity. For retinal detachments, it's really important that we have that hermetic stability in the eye. So in those cases, I prefer the valvulated trocars, okay? So now we're gonna remove it. I will start removing the 25 gauge. So when I am working with 25, I don't suture the sclerotomies. I only remove the trocar and do a little pressure in the sclera to seal that two-way trocar in the sclera, okay? So look, I will wrap the trocar under the port here, okay? Under it, I'll raise it a little bit, okay? And when I remove it, I make pressure with something, okay? That's enough. I displace the conjunctiva and the sclerotomy, it's sealed by itself if I made a well technique to insert it, okay? Remember, in case that you see that in the space of the conjunctiva, it's forming a bleb, maybe it's that the sclerotomy is not well sealed, and always you can do a small peritomy, you can cauterize it, you can put diathermy on the episcleral vessels, and put a stitch, okay? So now we're going to remove the 23 gauge trocar. Usually I like to put a 8-0 vicryl in the sclerotomies when I'm working with 23 gauge. There are another retina specialists that they don't want it. They feel that even if you make a well-constructed technique in the trocar insertion, you can have good seals, self-seals of the trocar, okay? So look, I'm going to remove again this trocar from here, make pressure, and then I will put a suture point in that sclerotomy. The technique to close the sclerotomies, you do a small peritomy since the beginning before insert the trocar. Then you put a little diathermy, you cauterization of the episcleral vessels, and then with 8-0 vicryl or 7-0 vicryl, you can close that sclerotomy with a simple knot, okay? Then we remove with success the superior trocars. Remember, the infusion trocar, it's always the last one that we're gonna remove. So if we remove it first, we're gonna collapse the eye, okay? So then we're going to remove the infusion trocar. I always remove the trocar with the infusion connected, okay? You can close the infusion if you feel better, and the same. With another instrument in your other hand, we remove the trocar and do a small massage to have a good seal in the episcleral zone and the scleral tunnel, okay? So then we finished and we have our surgery finished with success. We have a good trocar removal. Always look at the end of the surgery if there was sealed, if they sealed, if you see a bleb or if you see bubbles in case that you leave gas in the eye, maybe you will need to put to close that sclerotomy, okay? Remember, you have the choice of the gauge, of the location of the trocars, and if you are going to close it at the end or not. That's your choice, and to have a better success in your cases, okay?